of urodynamics. There's really a very basic. What is the aim of urodynamics? And the aim changes with time, and the clinical relevance has changed in time. And there has been an era of very much increasing numbers of urodynamic tests, and we are in the era of a bit decreasing numbers of urodynamic tests, and that will level off, I think, at a certain amount of tests done for certain indications. Nevertheless, urodynamics has a certain basic philosophy, and we have made a module on that basic philosophy, and Dr. McDougald is going to present that. Thank you. The floor is yours.
Well, we first wrote this module in 2006 when the idea of what was then the School of Urodynamics was mooted. And as Peter said, we've had to change our emphasis quite a bit with the passage of time. We also wrote this module before we had agreed on the standardization of the background, so it's white so that we can change it to the standard ICS formula when we've finalized on that. This was a collaboration between three of us, urologists and gynecologists, and from America, the UK, and Greek. And one of the most exciting things about it was working with people. There were some other people involved in the beginning who dropped out, but whose ideas have undoubtedly been incorporated into the final product. So, urodynamics is the measurement of storage and evacuation phases of the micturition cycle. From the time when a urodynamic study denoted the simple observations of urinary stream, the field has progressed with the development of sophisticated instruments to obtain complex recordings, becoming an integral part of the complete study of the lower urinary tract. And that was written by Tanago in 1991, before a lot of the recent controversies. This is a little picture of modern urodynamics lab with a procedure chair, just to give you a little bit of visual impact. So urodynamics, what does it do? It studies the dynamics, physiology of the urinary tract. It explores pathologies such as incontinence and obstruction. It provides objective assessment, and it allows for evaluation of symptoms and confirms or refutes a clinical diagnosis. But it's also an artificial reproduction of bladder storage and emptying. But it records intravesical and urethral pressures during the filling and voiding phases of the micturition cycle. So what's the aim of clinical urodynamics? To reproduce symptoms while making precise measurements. And we do this in order to identify underlying causes and to quantify related pathophysiological processes. What we're trying to do is to establish objectively the presence of a dysfunction and to understand its clinical implications. What does a urodynamic evaluation include? Well, there will be some pre-study investigations that are also very important. The clinical history from the patient, the physical examination, neurological, vaginal in the case of female patients, rectal examination, the micturition or bladder diary, post-void residual urine, preferably by ultrasound, as we've just discussed, and a midstream clean catch urine analysis. So urodynamics then has a number of precursors which are also important. What does the actual study itself involve? Uroflowmetry, which is non-invasive, cystometry, which is invasive with a storage phase, and pressure flow study, which is the voiding phase. Then we have now a range of advanced urodynamic investigations such as urethral pressure measurements, electromyography, endourodynamics, ambulatory urodynamics, and video urodynamics using fluoroscopy. What is urodynamics not? It's not just a recording of data. It's not a therapeutic method. It's not an investigation which can answer all the questions about disorders of urinary tract. It's not just a research tool. It's not just a laboratory investigation. Why do we do urodynamics? Well, O'Donnell in 1991 said urodynamic study is one of the most useful clinical techniques available for evaluation of the lower urinary tract. Is it the best way to assess It's the best way to assess storage and evacuation functions of the lower urinary tract. It evaluates capacity, compliance, competence, sensation, and stability. And it gives us what we all love, it gives us some numbers. Now then, when are we going to do urodynamics? Well, this is what the ICS recommendations in 2005 said: prior to invasive or reversible treatment or retreatment of all types of urinary incontinence except for the following: uncomplicated female stress and urge incontinence, post-void dribbling in males, male urge incontinence associated with other typical lower urinary tract symptoms for which surgical therapy has not been performed nor is planned, functional disorders in children that respond to a trial of behavioral therapy, and incontinence in frail elderly patients in whom conservative management has not been attempted. We should do urodynamics whenever there is any doubt about the underlying pathophysiology or doubt whether the incontinence is truly uncomplicated. We should do urodynamics in bladder dysfunction as an initial assessment and as part of long-term surveillance. Now we come to the contentious issue which has come very recently to the fore and which has led to a lot of controversial debate in the literature. Should we do urodynamics before surgery for uncomplicated stress urinary incontinence? Now, the studies have shown that the outcomes of surgery for stress urinary incontinence are not significantly different in patients who did or who did not have prior urodynamic studies. My answer to that would be, and this is a personal opinion, that if the outcome of surgery is not successful, then the next step which most people take is to carry out re-evaluation by urodynamics. But if you haven't done any prior urodynamics, you don't have any yardstick for comparison. And because treatment of stress urinary incontinence using tapes is so successful a procedure, then the number of failures is actually quite small. And you need an awful lot of people in order to say whether this is going to make any difference or not, having done prior urodynamics. And that study's not really been done. But there is one that I know of that's in progress at the moment, which is collecting results from a lot of people. Against all this, you have to balance the invasive nature of the test itself and the cost. And these, particularly the latter, are the things that have led people to re-evaluate, do I really need to do it? And have to say that, again, this is a personal opinion. I have personally changed my stance on this. I used to think that if a female patient came and when you examined her you were sort of having to do that at the end of the procedure, then she didn't have any symptoms of overactive bladder, then really it was really irrelevant whether you did urodynamics or not. You're going to put a tape in. But the problem is those few, and they are a few for most of us, who come back and they're not happy with the result. Now, the following ICI recommendations from 2005, which are grade C except where noted, that it's recommended that invasive urodynamic evaluation should be tailored to each individual and should at least include a filling cystometry with provocation and a pressure flow study of voiding. And that's a sort of bog standard minimum, together with one or more of the following as indicated for the individual patient: abdominal leak point pressure, urethral pressure measurement made by a technically sound method, simple neurological assessment, and simple assessment of anal rectal abnormalities. So can we call urodynamics a clinical science? Well, it's evaluation of dysfunction of the urinary tract. It perhaps suggests therapeutic management, and it evaluates the consequences of treatment. It can be used as a pure science in investigation of the pathophysiological basis of urinary tract disorders, evaluation of their natural history, objective evaluation and comparison of new treatments. So the science of urinary tract studies. As an objective measurement of urinary function, well, it provides us with numbers. And like I said, we like numbers because we can manipulate numbers and we can work out percentages and we can draw conclusions. Provides us of numbers with flow rates and pressures, enables us to make comparisons between different patients and different operative procedures and to objectively evaluate success or failure. But is it a science or an art? Because we know that studies that have looked at comparison of objective measurements of success or failure of tape procedures are very different from studies which ask the patient, what do you think? How much bother have you got? Are you happy with the result? So does it agree with the patient's perspective? But on the other hand, we know that the bladder is reported to be an unreliable witness. Do we accept urodynamic studies as the gold standard? Or do we see urodynamic studies as a method of investigating urinary dysfunction to be interpreted in the light of other signs, symptoms, and objective measurements? And I would suggest that that is the way we ought to go. How effective is the science? Well, urinary dynamic studies take place in a totally artificial setting. Women don't normally micturate in company. I know it's a little bit different for men, but we don't usually micturate with tubes in the urethra. Micturition is socially conditioned, so it wouldn't be surprising if it failed to reflect the real-life situation. We need to consider the patient, we need to consider the inhibitions, we need to consider the reproducibility of the test. We need to consider the equipment that we're using. Has it been accurately calibrated? Do all the machines measure the same parameters? We need to consider the operator, the say that the equipment is set up and utilized, the way the tracings are interpreted, this adequate training of people who are going to do the procedure. I think interpretation of traces is very important. I know that there are some very well recognised centres in the UK where traces are looked at in the absence of a patient. Now, I personally would regard urodynamics as a dynamic study, and you are with the patient and you look at the trace and you look at the patient at the same time. So when we're talking then, we have to standardise our procedures, and I think this is very important. And there are 4 components here. The standardisation of terminology, which we have thanks to the ICS. The standardisation of technique, which is one of the things I think we are hoping that this production of modules will help with. The standardisation of the equipment and the standardisation of training. Standardisation of terminology of low urinary tract infection as defined by in 2002 were written to be compatible with WHO publications and ICD-10. The definitions are descriptive observations, and the aim was to facilitate comparison of results and enable effective communication between different centres. But it provides definitions in terms of symptoms, signs, conditions, and urodynamic study observations. If you can standardise your technique, then you ensure high-quality urodynamic testing. Enables comparative studies across various institutions. Recognises that these studies are invasive, costly, and involve a significant learning curve for accurate performance in interpretation. And that's from Good Urodynamic Practice, ICS 2002. And I think also with standardisation of technique, something which we have discussed this morning, and that is standardisation of reporting. Elements of good urodynamic practice in a clear indication and appropriate selection of relevant testing components. You need precise measurements with quality control of the data and complete documentation. You need accurate analysis and critical reporting of the results, and you should not be performing invasive procedures without clear indications. Over-interpretation, over-expectation. It cannot be too highly emphasized that the presence of a trained urodynamicist during the test is essential for accurate interpretation. A recognition that urodynamics will not always supply the answer. I'm sorry, I've got a cough. And when there is discordance between the results and the patient's signs and symptoms, other investigations must be considered. Standardisation of equipment. Urodynamic studies are operator dependent. For instance, with pressure measurement, it's essential to set up pressure gauges to position the patient correctly in relation to the gauges and to zero with the gauge open to air. It's dependent very much on the equipment that we're using. It's tempting to accept an elegant printout as an accurate record. It's essential to calibrate regularly and to interpret in the light of the patient's symptoms during the test. So what leads us to a successful urodynamic study? Performing the study interactively with the patient. Continuous and careful observation of the symptoms as they're collected. Avoiding artifacts and correcting any unavoidable artifacts immediately. Again, ICS recognised early on that invasive urodynamic studies should be performed in accredited urodynamic laboratories by trained and certified staff with formal control of the quality of the results. And who actually performs urodynamics differs from country to country. In some places, doctors always do it and nobody else is allowed to. To this end, the establishment of national accreditation, training, certificate and quality control programs is highly recommended. Standardisation of training. You aim to produce recommendations intended for the training of beginners, both performing and interpreting in the field, and this implies that the training meets a minimum standard. It's not restricted to any professional group, only by the restrictions of any country's particular limitations. So we conclude that urodynamics is a science which demands the highest standard of calibration and accuracy of measurement. It's also an art in order to relate those measurements in a meaningful way to the patient's signs and symptoms, enabling accurate diagnosis and appropriate management. Thank you. I'm sorry about the coffee.
Thank you very much. Any comments? Andrew, you're welcome.
Margaret, thank you. Just one small comment that may be helpful in the document. You say calibrate regularly. I find that tends to put people off, and it might be more helpful to say check calibration regularly, because anyone can do that.
Yes, yeah, you're right. Thank you. I'll do that.
Who does urodynamics to reproduce the symptoms? In the light of being an objective observation, you start off with citing this, and then you end up with that your urodynamics has to show why the patient has signs and symptoms. And I agree more with the last part than with the first part. But it may be a matter of wording. It sounds to me that when you say you are reproducing the symptoms, that you are trying to find the things that the patient says to you. And you continue to say that the bladder is an unreliable witness. I think that the patient is unable to explain in the concepts that we have what's happening in the bladder, so I do not blame the patient nor the bladder.
No, I agree entirely. I mean, I think that
we've
come along with this for a long way, saying that the bladder is an unreliable witness, but you're actually making a subjective decision which you're choosing. Yeah. We're saying urodynamics is a gold standard, but I'd put that in inverted commas, because why are you deciding that that is better than what the patient's telling you?
I think it is.
But I'm
happy when the patient had a lot of complaints and I have a normal urodynamic study. I can say, okay, you have a lot of problems, but at least your bladder functions normal. So, and I'm happy with that. I see patients that have a lot of symptoms and a lot of signs, not incontinence, but other things, pain and frequent voiding and things like that and that. And I see a normal test. I'm extremely happy for myself and for the patient that apart from all the problems, the bladder function is okay. And I tell my patient, the bladder functions okay. This is a relief for me and maybe for you. And then we can continue solve all the other problems. But we are in philosophy now.
We are talking about the aims and philosophy of urodynamics. I think it's a fair point. I think that's a fair
So
point.
sometimes I'm happy that I did not reproduce all the problems that the patient is mentioning.
Yeah, I think that's a fair comment. But I think at the same time, you have to say, yes, you're happy, but is the patient happy?
Yeah, sure. We are both happy.
I mean, I get this, you see, with patients who've come and tell me that they've been pregnant for 2 years, and I tell them they haven't got a baby, and they walk out of my consulting room saying, but I'm still pregnant. They're not always happy.
Good, there's another comment.
Yes, it's more a comment than a question. We are talking about philosophy, but philosophy is not something, in the heaven, something that is practical also in our clinical use, I think, because I think that you have exactly catch the right point. That is, we are not only using urodynamics to understand the symptoms. We are using urodynamics to understand the function and dysfunction of the lower urinary tract. Used in this way, urodynamics are very useful. And probably this is the reason why it is also difficult to prove it in an evidence-based way, because we are not looking one aspect, but we are looking for several aspects, and this is very difficult to, demonstrate in an evidence-based system, let's say. So I agree completely with this philosophy, to not to just look at the symptoms, but function and dysfunction.
Other comments? Yeah, there's another comment.
I think you can just make it clear in both ways. It's both.
Yeah.
Well, it's both. It's a science
Sure.
and an art, and I think we're trying to say in this module that is really important to recognise both aspects of it. You know, what you think and recognise that you have input in. Like I say, you want numbers. You want something you can crunch. You want something you can deal with that's concrete. But that's not what the patient wants, and we have to kind of balance both these factors.
So the module ends in a balanced way. I think that's the balance that you want to have. It starts in a way that's frequently cited, and that I think is hindering progress in urodynamics. Other comments? No other comments.